Thank you for joining us virtually for a press briefing. My name is Kelly Chandler. I'm the Public Health Division Manager for Itasca County. Itasca County is hosting press briefings to highlight themes emerging in our community related to COVID-19 or frequently asked questions posed by our community members. We are providing twice weekly written updates for the media through the month of June. Today, we will address frequently asked questions related to COVID-19. We are joined by Dr. Dan Suler, Vice President of Medical Affairs and Family Medicine Physician, Grand Itasca Clinic and Hospital, Laura Veneps, Director of Patient Care Services from Big Fork Valley, Deb Morrell, Long-Term Care Director of Nursing from Big Fork Valley, Amanda Reed, RN Supervisor, Deer River and Grand Rapids Essentia Health Clinics. To start off with the situational update, we have 59 unique individuals in Itasca County affected by COVID-19. We have 12 deaths. We have had no new cases since our media release earlier this week. The death age ranges are from 57 to 94, and the positive case age ranges are from 6 to 94. We've had 24 males and 35 females in Itasca County affected by COVID-19. Our positive case numbers have slowed in the past 2 weeks, and this is similar to how the state of Minnesota is having positive cases come in. We are monitoring how this progresses locally and within the state of Minnesota as we move into further opening up of businesses and lifting some of the criteria for larger gatherings. We in Itasca County continue to encourage our community to stay safe and be diligent in slowing the spread of COVID-19. With that, we'll move into the frequently asked question portion of the presentation, and following, we will have a Q&A portion for the media. We do encourage the media to submit questions via chat. We'll ask our panelists to answer. Our first frequently asked question: what does COVID-19 likely look like in Itasca area over the rest of the year? And we will have Dr. Dan Suler from Grand Itasca Clinic and Hospital respond to that.
Hey, Kelly, thanks for allowing me to join this morning. So I think this is a great question, and the further along we get in this COVID crisis, I think the further we realize our modeling is falling short. For example, the early predictions this week and next week was supposed to be the peak within Minnesota, and as you mentioned, certainly our cases are slowing down, not only locally in Itasca County but throughout the state. What the future looks like, I think nobody can predict that. If we're going to continue to see small spikes in communities, whether it's living situations or meatpacking facilities such as in southern Minnesota, it sure seems like that will be the future for the next few months. And then the great wild card is, what does this fall and winter look like? And even the experts throughout the country are unable to predict that. So what I can tell you is the numbers are certainly, we're certainly seeing a plateau, and we may be on the backside of that spike as we're sitting today.
Thank you. And next question: what is the testing process like for COVID-19? And we'll have Laura Veneps from Big Fork Valley respond to that.
Thanks for having me today. So I can speak to Big Fork Valley specific testing, and it is somewhat different at each facility depending on their resources for what they have for testing as far as their internal equipment and their connections with external labs. Here in Big Fork, we have the ability to do PCR testing through the Minnesota Department of Health, and we also use an external company called LabCorp. Both of those tests require a nasopharyngeal swab, which is a somewhat uncomfortable swab collection where they use a synthetic polyester soft tipped Q-tip like where they insert it into the nose, back into the nasopharyngeal area. Can cause a burning sensation, cause you to sneeze or to have your eyes tear up, but it's quick and shouldn't have long-lasting effects. And then we do have an in-house Abbott ID Now machine here in Big Fork, which actually prefers the nasal testing, which is more of an external nasal swab that is just inserted in the outside of the nares and then able to be tested within 15 minutes. Less discomfort and quicker results with that one. And then we also have the ability to do an antibody test, which is a blood test. So it's a normal blood draw that's sent out to our external lab.
All right, thank you, Laura. The next question is one that I will take from Itasca County's perspective, and that is, how does contact tracing work? When COVID-19 began, and we actually see with other diseases such as pertussis, tuberculosis, the Minnesota Department of Health has traditionally taken the lead role on contact tracing. There's certainly rumors that that you're tracked and your technology is used to identify where you go to and where you travel and places you visit, and that is completely untrue. I certainly want to dispel that rumor. This contact tracing, there's a case investigation, and that's the person who tests positive, but then there's also the contact tracing, which is you identify if you're positive, who you've been in contact with for the previous 14 or right before your symptoms start, 2 days prior to your symptoms starting, or 2 days prior to your positive test if you don't have symptoms, and then anybody you've been in contact with closer than 6 feet and greater than 15 minutes. So if you were in a grocery store and happened to walk by somebody, that would not be considered a close personal contact. It's someone that you have been truly in close contact with for a period of time. That's how the virus is spread and what we know about how infectious it is. Again, it is an interview process and an education process. And so it's mostly done via the phone. So again, we determine to the best of someone's ability where the exposure occurred, whether it was travel, whether it was a congregate living setting, whether it was healthcare in the community, or unknown, because some of our cases certainly are unknown. We try to identify your symptoms, and we will go through the list of symptoms to learn more again about how the virus presents itself, when the exposure occurred, and then when you started to develop symptoms. So, we learn more about how close the incubation period typically is. And then once that's all gathered, we do move into more of an information portion. So we talk to you about managing your symptoms, how to stay safe yourself, encourage you to isolate in your home, talk to you about how to keep your household members safe. And then when you're likely not to be infectious any longer. And then we do discuss how to access essential services. So we're talking things like groceries or prescriptions or personal protective equipment. And that is a local public health role, is if you're unable to have family members or friends help you, assist you with accessing essential services, that would be a role that we provide for you. And then again, move on to how to prevent further contact. Again, it is an interview process done via the phone. It is voluntary. You certainly don't need to disclose information. A Tennyson warning is provided about how your information is or isn't shared, and we are going to talk a little bit later about limitations of data. Your privacy is very important, and we do keep things private. So the Minnesota Department of Health is moving to a regional hub model. So we do in Itasca County, we have 8 staff that are trained. As of yesterday, we are taking on our local case and contact investigations, and we haven't had any come through yet, but we will be monitoring that a couple times a day. We do receive lists of those who are positive. And then the Minnesota Department of Health did take this on, but they're moving to this regional hub model, and they are going to announce vendors who are going to manage the technology and the assignment of the cases. As best as possible, we'll have our local staff conducting local contact investigations. However, with the regional hub model, depending on capacity, number of cases, they certainly could be doing some contact tracing for the region and not necessarily just in Itasca County. But of course, again, we'll always try to stay as local as possible. Our staff have the expertise with our resources. So the Minnesota Department of Health has conducted follow-up surveys to persons who have engaged in the contact tracing, and overwhelmingly 99 to 100% their responses have been positive. They're grateful that they received a call. They're grateful for the information they were offered, and then the education on how to stay safe. It really has been a positive experience for persons, and we'll continue that locally as well. All right, and we will move on to the next question, which is how can we prevent the spread of COVID? And Laura Van Epps from Big Fork will take the question.
So in knowing that COVID-19 is a new virus, there's still a lot that we do not know about how it spread and how sick it can make people and exactly how it can pass from person to person. According to the Minnesota Department of Health, as of Tuesday the 16th, they believe that the disease is thought to be spread through the nose and mouth droplets when someone is infected, when they cough, sneeze, or exhale. And those droplets that are either due to coughing or sneezing or just plain exhaling can land in the mouth or noses of those around them. And so thus causing a respiratory infection for those that get enough virus exposure. So that's why the recommendation to stay 6 feet away from other people while in public is important, because it's maintaining a distance where you're less likely to get those droplets and become infected with the virus. The other part of the protection of the droplets is in isolation precautions for droplet is masking. So CDC has recommended, and along with the Minnesota Department of Health, wearing masking for both source control and for personal protection. So there's a good resource, there's a lot of resources on the difference between source control masking and masking for personal protection. And so masking is important on both sides to both control if you are infected from spreading the virus to others, and also for healthcare workers to not contract the virus when they're caring for those that are carrying the virus. Things that healthcare facilities have instituted for helping to slow or protect the healthcare workers with caring for patients that may have the virus. We have been asked by the Minnesota Department of Health to have active screening for our facilities. So asking questions, screening all those that enter our facility if they've been exposed or come in contact with somebody that has contracted the virus, if they have symptoms, what the symptoms are, and then taking a temperature of those coming in that may not realize they have a fever or elevated temperature. We have instituted personal protective equipment such as universal masking, so wearing a surgical mask for healthcare workers that are actively screening or taking care of patients within our facility, and then also requesting anybody on our campus to wear a cloth mask to prevent spread of virus for those that may be asymptomatic and on campus. So a lot of cloth masks have been made by the community, and we are grateful for those donations that have allowed us to be able to use them for source control within our facility. We have redone our facility to help with social distancing. So our waiting rooms have, making sure that chairs are 6 feet apart, trying to limit waiting room times, even having workflows where we can have patients remain in their vehicles until they're ready for their appointment and then be roomed right away. We have closed communal areas such as our cafeteria and fitness center until we can put practices in place that prevent the spread of the virus. We've instituted additional cleaning measures for all the high-touch surfaces throughout our facility to help prevent the spread of the virus. And then have instituted testing for those patients that are maybe coming in for surgery or procedures, or healthcare workers that may have been exposed within our campus to try to help mitigate the spread of the virus sooner than later. We also screen all of our hospitalized patients that are going to be in our facility so that we know right away if they need to have personal protective equipment or put in isolation. We have instituted a lot of equipment changes for COVID, especially with patients that are having a cardiac arrest or having life-threatening issues such as needing help with airway intubation equipment, specialized kits to help with that process, along with viral filters that help to mitigate the spread of the virus when we're working with somebody's airway or giving them support with their breathing. And a lot of training has gone into helping staff to become familiar with that new equipment and the recommendations coming from the experts in the field. We've done a lot of collaboration with both the Northeast region and the Northwest region. Healthcare coalitions, been a great resource, and bringing together all of the entities in those regions to have discussions and communication about protocols and policies and best practices. And I've been grateful for that collaboration. That's all.
Thank you, Laura. Next question, what special steps are being taken in long-term care settings? And Deb Morrell from Big Fork Valley will respond to that.
Yes, because our residents that we have here have more compromised systems than others. We have to have a little bit higher standards than they have for the people in the community. So we have not been able to have face-to-face visitors with families are not allowed into the facility. Vendors are screened, and there's only certain vendors that are allowed in the facility. Also, we've had to make a lot of changes in our day-to-day plans for the residents and trying to keep them so that they do have some contact with people. We've provided with laptops and iPads, so there's a lot of Zoom meetings and FaceTimes and whatever with their families. We are sending out weekly newsletters so they know exactly what's going on with their loved ones. Just late last night, it was told to us that they're going to start loosening some of the restrictions on having parking lot visits. So we're going to have to do some more work on figuring out how we can do that and still social distance and keep everybody safe. So pretty much everything that we used to do day to day has changed so that we are more diligent with all of our infection control practices.
Thank you, Deb. The next frequently asked question is regarding data. The state provides quite a bit of detail in their daily data, but what else can we understand here? I know it certainly can be frustrating when we're asked questions locally about our data and specifics about where people are living and what facilities are they coming from, etc. Oftentimes our answer is we can't provide that for the privacy of the individuals and families. You know, HIPAA laws very much are in place, and you know, it's for the protection of the person. You know, and we take this very seriously. You know, we're certainly never trying to not be transparent or provide as much information as we can to the public. But again, if there's any piece of data that could be potentially identified and linked back to a certain person or family, that would be in violation of privacy laws. And so we don't offer a lot of the extra information. I know early on, there were a couple of facilities that came on to one of these press briefings and talked about some positive cases, and that completely was, you know, their decision to do that, and not something that we could identify ourselves. So some of the information we have about our local cases, we have, again, 59 unique individuals. There are more positive tests, but there are some people who have been tested more than once for various reasons, and so have accounted for more than one positive test. We have 24 males, 35 females, age range is 6 to 94. Deaths, age range is 57 to 94. As far as race, not everyone has identified their race in the contact investigation, and so we really don't have a good picture of the breakdown of that locally. Again, we can offer zip codes to potentially identify where someone might live, and we can't identify facilities. I do want to speak to the facilities that are identified on the Minnesota Department of Health website. So to be included in their list, you have to have a facility that has over 10 beds, and you have to have more than one positive case. And we do have multiple facilities that have had either staff or residents identified, but again, they might not be listed depending on the amount of beds they have, or if there is or is not more than one case. So there are some limitations to that. There's been some differences in licensing. You know, we could have the Department of Health, we could have Department of Human Services, we could have Department of Corrections. It's all different how places are licensed. And so where or how they're identified could be different solely based on that. I also wanted to touch on, why does Minnesota look so high in our long-term care numbers and deaths? And, you know, just at face value, it can seem like we're higher than the national average, but that really isn't exactly accurate. Minnesota defines long-term care broadly, more so than other states. We include nursing homes, assisted livings, memory cares, transitional care units, hospice, group homes, mental health facilities, and substance abuse treatment facilities. So when other states are talking about long-term care, they may only be talking about skilled nursing facilities, and they might not be as broad as we are. So again, our numbers could look higher. If a death occurs in a hospital here in Minnesota, but they were previously living in a congregate care setting, that will be called a congregate care setting death, not a hospital death. So that's a little different. MDH has case and death counts, not rates. And so that's a difference in how data is defined. Medicaid Center for, or Medicare, I'm sorry, has released data on nursing homes throughout the country. And this indicates that Minnesota actually is lower than some of the national averages. Again, we provide as much data as we can to try to stay ahead and really to be as transparent as possible. But again, we do take the privacy of those affected very seriously. And so there will be some limitations on that. Anyone is more than welcome to reach out and ask questions. Just whether or not we are able to provide a response will be dependent. So next question, why do we send local COVID patients to Duluth or the Metro? And I will respond to that. As Laura had mentioned, our hospitals and clinics are involved in regional healthcare coalitions. They've all been planning for 3 months on for COVID-19, and they all have surge plans, meaning if they're overrun with cases. And the plan is at this point to transfer those who are in need of more care to be sent to facilities that have larger ICU staff and capacity. That is the plan. However, our clinics and hospitals are equipped to care for patients locally as well if that's needed. So in general, it is the plan. It's the plan for all, but yes, we do have the capacity locally. That's a question we receive a lot. Are our clinics and hospitals prepared? And yes, they are prepared. Next question. There's a lot of talk in the news and social media about possible treatment options. What is available or likely to be available soon? And Dr. Suler will take this on.
Yeah, thanks. I can take this. We certainly get this question a lot. And this too is evolving as we go through the course of COVID. Early on, there's a lot of publicity about two medications specifically, one called hydroxychloroquine, which is actually used for malaria or rheumatoid arthritis. And there's a second medication called azithromycin, which is an antibiotic. And early on, you know, especially on the East Coast, New York, and on the West Coast in Seattle, when they had large numbers of cases, this was a medication that was, this combination was given to a lot of patients. It was felt to be appropriate. However, as we've gone through and collected data, the data and the statistics show that really being those two medications provided no benefit from being on no medications. And in fact, the combination of medications for many patients caused a lot of side effects and potential harm, such as cardiac or heart abnormalities. And so, you know, as we sit today, the initial thought of hydroxychloroquine and azithromycin being a good treatment option has really been put on the wayside, and that's not being used in medical facilities anymore. The latest medication that people hear about a lot in the publicity or in the press is something called remdesivir. And what that is an antiviral medication that's given through an IV. That's only given on patients that are very, very ill in hospitals and in ICUs. It has been shown to speed up recovery. So compared to folks that don't take remdesivir, people will return back to normal quicker. The limitations are it's a new medication, so the supply is very low, which is the main barrier right now. But going forward, through the next 12 to 18 months, that's going to be a tool in our tool belt that we'll continue to use more and more frequently. And then finally, the last thing I wanted to touch on is convalescent plasma. That's also been in the news quite a bit. And what convalescent plasma is it's plasma that's gathered from patients who have had COVID. When we are infected with COVID, we develop antibodies to try to attack COVID. Once a patient has returned back to normal health, they are then eligible to donate plasma. We take the antibodies out of that plasma that could potentially help somebody who hasn't been exposed or hasn't been able to develop that antibody response, such as those that are older or have more comorbidities where they just can't mount that antibody response. Again, the limitation here is, of course, somebody has to have COVID, recover, and donate the plasma. Locally, I know our partners at Essentia are working on this and actively collecting plasma. Mayo Clinic, University of Minnesota as well. And so as time goes on, hopefully that supply will grow larger to be another tool we can use to help treat patients if they're ill enough to need that sort of treatment.
Great. And we have a couple more frequently asked questions enabled for today because we do have some questions in the chat box as well. What is antibody testing and what does it mean? And Dr. Suler can take that one.
Yeah, I can touch on that. Again, antibodies are white blood cells that our body makes in response to an infection. And the thought behind it is the antibody test would help determine if you've been infected and maybe didn't have symptoms. The big question is, if you have antibodies, what does that mean? How long are you protected? And really, it's unknown. Again, I remind people, 6 months ago, there was no such thing as COVID-19. And so we don't know how long these antibodies will last. Some of our antibodies we produce to measles, for example, last for the rest of our life. Other antibodies, such as influenza, last 6 to 9 months to get us through the flu season. We suspect that COVID antibodies will be obviously somewhere in that range, probably on the shorter range. It's not going to give us lifelong protection. But again, until we have more time to study this and follow this along, it's really unknown how long that antibody will provide protection.
Thank you. And our final frequently asked question, how would you describe the financial impact that area facilities have experienced because of COVID? And Amanda Reed from Essentia Health will take that question.
Thanks, Kelly, for having me today. With the onset of COVID-19 and the pandemic, in conjunction with the stay-at-home order, facility preparation efforts, surge planning, increased PPE expenses, and a number of other factors, hospitals and healthcares have had an experience with a rapid and substantial loss of revenue. Due to this loss, many healthcare facilities have been faced with difficult decisions to offset the significant decline in patient volume, such as placing staff members on admin leave, flexing staff hours, staffing to volumes, reducing physician and executive leader compensation, scaling back services, and reducing the workforce. An effort to increase patient and staff safety and conserve PPE, non-emergent procedures were postponed, outreach specialty services were postponed, and healthcare facilities limited in-person access, especially in primary care. On top of that, community members were afraid to seek medical care and fear that if they were to come into our facilities, they might in fact contract COVID or become sick. So this caused them to defer their preventative care and also sometimes emergent care. With the state governor's guidance, healthcare centers have started to resume elective procedures and surgeries, and patients whose procedures had been postponed previously are now being contacted to reschedule. Healthcare facilities have also increased face-to-face visits and preventative services such as mammography, immunizations, stress testing, physical therapy, occupational therapy, and we are actively reaching out to at-risk populations to try to get them into these appointments that they very much need. In order to do that, facilities have expanded and improved upon existing safety measures and now have implemented new ones to make sure our clinics and hospitals are as safe as possible for patient care. COVID testing supplies and testing locations have increased, and state testing guidelines have broadened, allowing us to test more individuals. Facilities have been collaborating with congregate living centers to provide necessary testing for client admissions and discharges to assure safety of their staff, the clients that they serve, and then also the community. Also, surge planning efforts, which I think has been touched on a couple times today, and then also safety preparations have prepared healthcare facilities for increased volumes of patients in response to COVID if we were in fact to go into a surge situation. And the last thing I kind of wanted to touch on was initially grants and federal funding did help soften the impact and blow of the COVID-19 pandemic for healthcare facilities, but that funding isn't enough to financially sustain current working conditions or patient volumes. So with increasing patient volumes, or we hope to see increasing patient volumes at our facilities, we'll be able to bring back staff to match the demand, as getting back to normal functioning is the most important thing right now for financial stability and overall community health and well-being. Thank you.
Thanks, Amanda. We are at 10:31, but I will go through a few of the questions in the chat. Kathy Lynn from KOZY requesting the graph or pie chart on the age ranges of COVID-19. Yes, I do have that available, and we'll send that out to the media. 60 to 69 and 80 to 89 are the two highest, and then 20 to 29 age range is following in third, but I will send that out. Kathy from KOZY, I understand the CDC was in Grand Rapids asking questions at Grand Village, heard that they were impressed, and is that accurate? So the CDC and MDH have been in town working with their skilled nursing facilities. This is a routine infection control discussion. Again, it's not for any one reason or another. They do visit all the skilled nursing facilities and talk about infection prevention and provide education as well. So yeah, they were in town. That particular facility hasn't been listed on the Minnesota Department of Health site thus far, but I myself and our emergency preparedness coordinator were able to participate, and very informative, long visits, but again, very informative, and it's meant as an educational process. Our cloth mask donation still needed. Angela Cleffman from Big Fork Valley they are accepting fabric masks. They can contact Angela, and her information is in the chat. And then Elder Circle is also taking masks. Grand Itasca and Itasca County are working on getting some masks distributed outside of Grand Rapids proper, and we'll be working collaboratively on that in the next couple weeks. So the answer is yes, cloth masks would be great. And yep, Cassie from Grand Itasca also commented that cloth masks are being accepted as well. Kathy from KOZY, how are the rest of our long-term facilities doing? How many other facilities have at least one positive case? How many facilities are there? So skilled nursing facilities, there is 4 in Itasca County, and there's quite a number of assisted livings and some disability homes, foster homes. So we do have quite a number of facilities. The only facility that I can speak of at this point is the one that is listed on the Minnesota Department of Health website, and the one that early on was in the press briefing because they announced it. Other than that, we do have other facilities that have had either staff or a member that had positive cases, but I'm not able to identify who they are or how many cases they had. Other questions? Otherwise, thank you so much for joining us today and for allowing us to go over. Everybody stay well. Thank you.
At Grand Rapids State Bank, we've been a trusted financial advisor to our customers since 1914. We're local, community bankers who understand what it takes to manage a business through thick and thin. Grand Rapids State Bank, your community bank, serving people throughout the Northland.